firmly standing as the cultural vanguard of West Java, Indonesia, nourishing the intellectual life of the nation, working for the benefit of the global world. This is Universitas Padjadjaran. Inspired by the vision of the Asia-Africa Conference, attended by representatives of 24 countries, the establishment of the university was the realization of the vision of the cultural figures of West Java to found an institution of higher learning in the cosmopolitan city, to educate and set forth to society dedicated and qualified individuals. Today, UNPAD has broadened its wings to encompass various disciplines and multidisciplinary academic endeavors through the efforts of 16 faculties and 1 postgraduate school. To achieve its mission to build the capacity to adapt and innovate in the face of the rapid development of science and technology at the international level, UNPAD is determined to become the center of research and innovation for the good of the nation and the world by continuously nourishing research and developing technology to create innovations in various disciplines. Currently, 36,000 students are registered at UNPAD, and more than 200 international students are registered in different programs, degree and non-degree. As an effort to constantly improve the quality of education, Universitas Padjadjaran is supported by approximately 2,100 professional faculty members with reputable qualifications. To achieve the goals of its mission, UNPAD has also established notable research centers, which demonstrate serious commitment to and focus on achievements in a number of strategic fields, such as the Center for Sustainable Development Goal Studies, the Center for Environmental and Sustainability Sciences, the Academic Health System, the Center for the Digitalization and Development of Sundanese Culture, the Center for Innovation and Pharmaceutical Services, the Center for Nanotechnology and Graphene Research, to name a few. Equipped with a central science laboratory network and a science and technology complex in the Center for the Development of Science and Technology on the main campus, Universitas Padjadjaran has risen in its role as a leader in higher learning geared towards innovation. UNPAD also fosters collaboration with other institutions involving all stakeholders.
Universitas Padjadjaran commits in providing benefit and service for the good of humanity and the preservation of the environment. This is a great enterprise which cannot be done alone. UNPAD believes that in the spirit of collaboration, this vision may be achieved. We invite you who have the same vision, a good intention to care for human life and the environment all over the world, to work with us, build collaborations, create a better world together.
Universitas Padjadjaran grew out of the community and has made it its duty to give back not only in the form of the dissemination of knowledge and information, but also through socially responsible activities such as student fieldwork, community outreach programs, and action research seeking to make direct impact on the community. With its feet firmly grounded in the local communities and environment, UNPAD is also making great efforts to take steps towards internationalization. It offers special programs for international students to maintain its global network and make its strategic and reputable place on the world map of higher education. As a site for the personal development of young minds and bodies, UNPAD supports a wide variety of student activities. UNPAD also provides students with libraries with an extensive collection of books, periodicals, and study materials, comfortable dormitories, health and fitness services, free on-campus transportation, and other supporting facilities which UNPAD continuously upgrades and improves. While being committed internationally recognized quality research, UNPAD maintains also its dedication in preserving traditional cultures as the compass for all of UNPAD's activities on and off campus. As of now, UNPAD have set forth unto society 200,000 graduates in various fields of work, including strategic government sectors and crucial multinational industries. Works for the good of society, bringing innovations and sincere contributions to humanity. Universitas Padjadjaran, the pride of West Java, working for the benefit of the global world.
Are you interested in learning about cleft lip and palate with experts from around the world? And you can learn this for free while gaining 3 credits. Come join our online course in collaboration with Faculty of Dentistry Universitas Padjadjaran and Sponsoring.
Greetings from Transcendent 2021 Massive Open Online Course in Cleft Lip and Palate held by Faculty of Dentistry, Universitas Padjadjaran, collaborating with SmileTrain and YPPCBL has been going on for a few weeks. My name is Raisha. I'm a student from Faculty of Dentistry, Universitas Padjadjaran. Good morning, good afternoon, and good evening to everyone here. Greetings to Dr. Benedict Akintububo, Chief Consultant Maxillosurgeon, Federal Teaching Hospital, Gombe, Nigeria. Thank you, Doctor, for giving your time here.
Thank you so much.
Yeah, we hope you are doing well and stay healthy. What time is it, Doctor, in Nigeria?
It's 2 o'clock now. Just a few minutes to 2. 9 minutes to 2 o'clock.
Good afternoon then. It's actually 8 p.m. in Indonesia.
Okay, that's nice.
Yeah, we also have Dr. Erli Sarilita, M.Sc, Ph.D, a lecturer from Faculty of Dentistry, Universitas Padjadjaran, Indonesia, as our moderator. Thank you, Doctor, for being here. Greetings to all of the participants. We thank you all for participating in this course and thank you for attending this live discussion session. So, Dr. Benedict, today is our 5th live discussion in the 4th week. In the week 4, we are learning about alveolar bone graft, cleft anesthesia, common anesthetic complication arising from cleft surgery, and post-operation nursing care of cleft patients. Today we are going to discuss about alveolar bone graft with Dr. Benedict Akintububo. This live discussion will be separated in 2 sessions. So for first session, Dr. Benedict Akintububo will answer the question that have been filled out by the participants in the M.Sc website. The question will be presented on the screen, and then for second session, we will also accept more questions from the participants. Participants can ask the question directly to the doctor or through the chat section. The participants should write down the question, their name, and where they are coming from. So, doctor, for your information, the participants have already watched your lecture video about this topic, but I think not everyone cannot make it into today's live discussion. But I'm pretty sure that more than 300 participants that have registered into our course have watched your lectures. This discussion also will be recorded and also will be available in MOOC website, so the participants can rewatch this video in case they cannot make it today or they want to rewatch the video.
That's all right.
Now I would like to give the spotlight to Dr. Erli Sarilita as our moderator and also Dr. Benedict Akintububo as our speaker. So Dr. Erli, you may start the first session and lead today's live discussion. Thank you so much. We can move on to the first session.
Thank you, Raisha. Dr. Benedict Akintububo, it's very nice to meet you here today. How are you, Doctor?
I'm fine, thank you. And you? Good afternoon.
Good. Thank you very much for your kind sharing your time and knowledge here today. This is a very interesting topic, Doctor. Thank you for giving us the lecture. Some of the participants who watched your lecture, they posted questions in the online course. So today we will show you the questions and maybe you can help us to give insight about the alveolar bone graft. Committee, let's move on to the first question.
Okay.
So from Rashid Abdul Aziz from Universitas Pajajaran, what type of bone grafts do you prefer for the reconstruction of the alveolar cleft? Does the autologous bone always provides a better outcomes than another alternative graft material such as artificial bone graft substitutes?
Thank you so much for this very interesting question. Personally, I prefer the iliac cancellous bone grafts because you are sure of 100% of bone healing and tooth eruption into that area. And it is very easy for me to raise the iliac bone graft than taking other bone graft because the amount of cancellous bone you get from the iliac bone is quite enormous. Even when you have a bilateral alveolar cleft, you can even use only one leg rather than going to the second leg to harvest bone. So I prefer using iliac crest cancellous bone with a little bit of the cortical bone to line the floor of the nose. Regarding autologous bone, well, I doesn't have much idea because I've not been using them. But autogenous bone graft is always the best. But in case if you are going to use autologous bone, as in my lecture that I gave, it will reduce the amount of cancellous bone you might need to harvest from the iliac crest area and reduce the morbidity. But research is ongoing as to the use of autologous bone, because that is what the whole world is turning to now, and research is still ongoing, especially as regarding beta tricalcium phosphate. It's a synthetic bone graft. Research is on it. If it comes out to be the best substitute, then in future we might not need to go and raise bone graft again, reducing the morbidity to the patient.
Okay, thank you, Doctor. That's very clear. Next questions. It's from Sunny Wong University of Sydney. So, deciduous teeth located close to the cleft, which may interfere with the bone grafting. When would be the best time to remove them? 6 months before grafting, or 2 to 3 months prior, or during the alveolar bone graft?
Thank you for this question. Well, most patients that I have, most of them doesn't have deciduous teeth because majority of them are between the age of 9 to 11 years. Even the one I did this week, one of them was 12 years, so there was no deciduous teeth there. But even when you have deciduous teeth in few patients, I don't remove them. I still leave them intact in order for me to be able to have a better closure of the mucoperiosteum flap. Because if you remove the teeth, then the flap is likely to fall into the socket when you are closing it. So if you still have your deciduous teeth there, just manage to close your flap around them. It heals very well. And as soon as the permanent tooth that's supposed to erupt into that place is coming through, once you have your bone grafts healing, then definitely the deciduous teeth will finally come off. But I don't do it routinely to go and remove deciduous teeth. I normally leave them, they are still present.
Okay, thank you, Doctor. So let's move on to the next question. From Hasna Faza, Universitas Pajajaran, does the occurrence of alveolar cleft has another correlating manifestation on the bone density of the maxilla?
Yes, well, it has, because the cleft itself, depending on the size of the cleft, if it's much, then definitely the density of the alveolar bone in that area will be very reduced until you grafted it. But if it's a small cleft, it might not have much effect on it. But that is one indication for alveolar bone grafting is for you to increase the bone density for the teeth to erupt into it. Because if there is not enough bone, the tooth that's supposed to erupt into that cleft area might not likely to come out. Just like in the early 90s, when rib bone is being used for the grafting, they find out that the density of the bone formed is very, very reduced as compared to the iliac bone that we are using now. So definitely with cleft, there is a reduction in the density of alveolar bone in those areas. But with the grafting, the density will improve and the tooth can easily erupt into the cleft after the bone has healed.
Okay, thank you, Doctor. Okay, next question, please. From Zain Irfan, Universitas Pajajaran, does the graft rejection often occur as a complication? How do you prevent this from happening, Doctor?
Well, we've done over 100 alveolar bone grafts in the previous 7 to 8 years. We've not had any failure. But the technique you use is of paramount importance in order for you to prevent failure of the grafting or rejection of the grafting. One, the flap tissue must be enough to completely cover the bone graft. If the bone graft is not completely covered, if there is seepage of saliva or water or any food particles into the area you grafted, it's likely going to be rejected. But that is why the technique is of paramount importance. Complete closure of the cleft, the graft is very, very important, making sure you have enough mucoperiosteum. In the lecture that I gave, if you raise your flap and you find out that the cleft is so wide, especially in bilateral, and the tissue cannot close the cleft as at that stage, then you don't go ahead and do the bone grafting. You close the flap back until you have enough tissue to completely close the graft in order to prevent any breakdown. So in the past 7 to 8 years, we have not had any breakdown, and we are trying to mitigate against it because it is difficult to, you can regraft, but it's always good to have a first-hand technique that is going to guarantee you a complete grafting of the place rather than having a failure and you have to go and do regrafting. So we will not have any failure in the past 7 to 8 years.
Really useful experience from Dr. Akintububo. Let's move on to the next question, committee. Oh, that's the last questions from the online course platform. while we're waiting for the questions from the audience here, Doctor, I have one question for you. So
Okay.
for cleft palate patients, from the first surgery until the last surgery, how many in average, how many surgeries they usually need
Well,
for the cleft?
it depends on the type of the cleft. In a patient with cleft lip, cleft palate, cleft alveolar bone, then is it unilateral, is it bilateral? If it's unilateral cleft lip, palate, and alveolar bone, they have at least 3 surgeries. At 3 months, they have their lip repaired. At 12 months, 12 to 14 months, or maximum 15 months, they have their palate repaired. And by the time they are about 5 to 6 years, at this preschool age, if the nose is flattened or the columella is not straight enough or is shortened, then lip and nose revision will be done before they start primary school. And then the final one is the bone graft between the age of 8 to 11 years. So most of those with unilateral cleft lip, palate, and alveolar bone have like 4 surgeries. But if it's bilateral, there's difference now. In bilateral, they have their lip done maximum between the age of 4 to 6 months, because you need enough tissue in bilateral to close the lip. At 3 months, most of them might be too small. I normally leave them till between 4 to 6 months old with enough weight and good size to have enough tissue to close the lip. Then by 1 year to 15 months, we do the palate. Then when it comes to nose and lip revision, we still apply the same procedure 5 to 6 years of age. Then the alveolar bone graft depend on the size of the cleft now and the amount of tissue that you have in the prolabium area. In some cases, you find out it will be difficult for you to do bilateral alveolar bone graft at the same time because you don't want the tissue on the prolabium to die off. If the tissue is not enough to cover the whole of the bilateral prolabium, then you do one side first. Then after 6 months, you can do the other side. But if the tissue on the prolabium and the surrounding adjacent tissue is good enough to close all the bone with the grafting, then like the one I did this week was a bilateral cleft lip. But we did the grafting, the 2 bilateral grafting at the same time. So because we were able to get enough tissue to close the grafting. So these are the different steps and the different stages involved in all our patients. But sometimes you find out that when you do your palate, if some still have fistula, small fistula here and there, then they might need to come back for another surgery before the age of 3. So we close the fistula before they are 2-3 years old.
Okay, thank you, Doctor. Very clear answer. So I think we still have more questions from the participants of the online course. From Mutiara Azahra, I read in some journals that pre-surgical orthopedics and gingivoperiostoplasty can reduce or even eliminate the need of cleft child to undergo alveolar bone graft surgery because it could facilitate the eruption of the tooth. Which procedure do you think has the most advantage to the patient between those two? Thank you, Doctor.
Well, this is a very good question, and there have been a lot of debates about this. In early 90s, this is where alveolar bone grafting started from. They call it primary alveolar bone grafting, orthopedic surgery, gingivoperiostoplasty. But they still find out that there is a lot of complications. One, there is not enough bone. The bone density was small. It's difficult for the tooth to erupt into those areas. And at the end of the day, when you do all this at the primary stage, you still have a cleft left behind. So that was what led to secondary alveolar bone grafting. In the early phase of grafting, it was called primary bone grafting. But the result was not too good as we are having with the secondary bone grafting. This is the early stage of bone grafting these are the techniques that is being used. So we don't use this technique any longer because you are going to have a lot of complications. And at the end of the day, you still have to do secondary alveolar bone grafting. And the tooth that is even erupting into the cleft area does not erupt. It's either it's lateral incisor, or sometimes occasionally in a few cases you have central incisor, but majority of the cases is the canine that erupt into the cleft side. And the canine is not going to erupt until the age of 10 to 11 years, or in a few cases 12. So doing primary alveolar bone grafting have its own complication, and it does not give a better result as compared to secondary alveolar bone grafting. So we basically do secondary alveolar bone grafting. Now, all these procedures are the things that is being done at the early phase of 1990s.
Okay, thank you, Dr. Committee, is this the last question from the?
I think there are more questions.
Okay. Okay, this is from Dr. Andrew Lauren from Universitas Padjadjaran. He's the orthodontic resident of our university. Regarding alveolar bone grafting in cleft patient, is it possible to have dental implants in the future? And how about the density of the bone post alveolar bone graft procedures?
Well, I've not done any implants into those bones, but with the available record to us, or data that we had now, most of the cases that we have done, the bone density is very good, the height is very good, the weight is good, and if you want to do implants, you can go ahead and do implant on them. That is why assessment is needed post-surgery. You must take X-ray, at least 3-4 X-ray, 6 months, 1 year, 2 years. And once you have that done, and especially when the tooth has erupted to the grafting area, you can see how strong the tooth is. So all this shows that it's possible that you can go and put your implant, but you must assess properly first before you put the implant. But the basic thing in alveolar bone grafting is that the technique must be right from the beginning if you have to get it right. Because a repairing cleft lip nowadays, that's what we call primary open rhinoplasty with the lip repair. Not like those olden days where lip are just being repaired, the floor of the nose is not repaired, the rhinoplasty is not being done. All of them are done together now in order for you to get a better result. So that in the future, the amount of bone that is being required, because once you do the floor of the nose, then it reduces the size of the cleft. It's not the widening. But if the floor of the nose is not being repaired when the lip is being repaired, then you're likely to have a wider cleft. And when you're now doing your alveolar bone grafts, you must make sure you get enough cancellous bone up to the alveolar margin in between the teeth in all those areas, all the 5 walls, whether medial, lateral, posterior, anterior, floor of the nose, and the floor of the cleft itself. So once you get enough bone there and you follow up with your X-ray, you find out that the density of the bone formation there is quite very good. That if there is no tooth erupting there, you can put implant in future.
Thank you, Doctor. I think that is the last question. While we're waiting for another question from the audience here, I have another question. So you said your what is it? The procedure of choice is the iliac bone graft.
Yes,
using iliac bone.
That's what we use in our center.
Yeah. Why you prefer to use iliac bone, and in what condition that you cannot use iliac bone, so you have to choose another bone?
In every condition, you can use iliac bone because every individual have thick and good cancellous bone in the iliac bone area. Some use tibia. The tibia, where they said is the mobility is quite very low compared to that of iliac bone area. But depending on your experience, And then the amount of cancellous bone you can get from the tibia bone is not as much as from the iliac bone. Just like the one I did last week, it was a bilateral cleft. And I was able to get enough bone from one iliac area, but the girl was 12 years old. So there's no need for me to go and open the other leg, which will affect the mobilization of the patient. But if you are going to do tibia bone, you might have to take from both legs, which you are trying to make sure the patient is able to start walking as early as possible. But we are using both legs now. That one is less painful, but will you be able to get enough cancellous bone from there? No, I won't do that. And one thing we have to know is the fact that with your experience and with your knowledge, it's always good to use what you know how to use best, and which is going to give you a better result, rather than trying to follow what the world is saying. Because I would say, okay, tibia bone is good to use. Will you get enough bone from there? Must you go to the two legs? No, it is not compulsory. You can get from one side and get good cancellous bone, use that side. So my experience with iliac bone graft has been excellent. So, and I prefer to stick to it rather than going to another technique.
Okay, Doctor, thank you. We still have one more question here from Gretanza. I will read it to you from the chat box. What is the most current updates on the osteoplasty of alveolar cleft? Is there any developing research about this scope?
Sorry, I didn't get that question. Sorry, I didn't get the last question.
Okay, committee, please put the question in the slide, please. Committee. Okay, here the question from Gretanza Hendra.
I got it now.
What? Yeah.
Well, a lot of, as I said in the lecture, a lot of research is ongoing in order to prevent, not to use autogenous bone graft, because autogenous bone graft also have its complication, the morbidity, the damage to nerves, the mobility of the patient, and possibility of damage sciatic nerve. You are taking iliac bone, or if it's in the chest, you are taking the rib. So people are looking at other alternatives that you might not need autogenous. You can use autologous. The one that is promising as at today is beta tricalcium phosphate, but the research is still ongoing and it's very expensive. So in developed countries, even though if the research is done and it shows that it could be better than autogenous bone grafting, where's the money to buy them? So we might still go back to our own old ideas of doing things. It's just like today, in developing countries, they are talking about tissue glue, where they are no more using sutures. But we can't practice that in developing countries. So we still have to use our old technique of getting things done. So there's always research ongoing to find an alternative rather than using patient-owned body parts.
Okay, thank you, Doctor. Committee, can you confirm that this is the last question of the session? Committee?
The last question is from Faras Reza, Doc.
Oh, from Faras. Okay.
Yeah.
Yeah, from Faras Reza, Universitas Pajajaran. Since the alveolar bone graft is being done at the age of 8 until 11, will it affect the development of the craniofacial bone? Is there any chance that it will cause maxillary hypertrophy? And how do you manage it?
Well, it is possible, but with the little experience we have in the past 20 years, like the previous question I was asking about gingival perioplasty, the idea of primary bone grafting was to prevent the maxillary collapse or retrusion of the maxilla. But research found out that the result was not good. In those patients that are still going to have maxillary retrusion, they will say have it. But what improved the maxillary not to get hypoplastic or to get retruded is your technique of surgery. Because in a patient with cleft lip and palate, you must do a meticulous surgery. You must be careful with all the center of growth that they are not being damaged when you are doing your surgery. And that's why proper training is required, because they have more cause of maxillary hypoplasia than the cleft itself. Because if the surgery is traumatic, some of the growth center is being tampered with, especially when you are taking, if you are doing palate and you are taking some of the tissue that covers the vomer, you must be very meticulous that the vomer is not being damaged, because that is where you have more growth of the maxilla. So once you tamper with that bone, then you are going to have retrusion. But with most of the patients that we did secondary alveolar bone grafting for, we found out there's not much hypoplasia. There's no much retrusion. So that age of 8 to 11 still work out very well. And if you look at the indications I gave or the results, why you need to do secondary alveolar bone grafting, you find out that it helps the nose to be raised up. That is why when you are repairing your cleft lip at the age of 3 months, we should not make it the same size like the non-cleft side. That is the same height. The cleft side should be a little bit, the nose should be bigger than the non-cleft side, because the growth will catch up with each other. And then when you finally put your bone graft, then you find out the nose is being lifted up, because you've lifted the floor of the nose, and the bone, the nose will now come up better. So if you make it at the same level in your initial repair, that means the cleft side of the nose now will be higher than the non-cleft side. So these are the various techniques you have to look into when you are doing your surgery in order for you to prevent maxillary hypoplasia. Because if you don't take all these things into consideration, then you are going to have much problem than the cleft who is causing retrusion. So the surgical technique is much more important. And with the experience we have not seen patients much having maxillary retrusion, provided you follow a meticulous technique in carrying out your cleft lip and palate surgery.
Thank you, doctor. So the surgical technique is the key to the preventing the maxillary hypoplasia. Doctor,
Yes.
that is the last question for our live discussion session today. On behalf of the committee, Faculty of Dentistry, Universitas Pajajaran, I would like to extend gratitude to Dr. Benedict Akintububo for his time spent teaching us today. So, Doctor, I will give the session to the Master of Ceremony, Raisa.
Thank you so
Doctor.
much. It was my pleasure.
I think that was the last question, which means we have reached the end of today's live discussion. It was such a great opportunity for all of us hearing the valuable knowledge from Dr. Benedict Akintububo on this special occasion. And also thank you for Dr. Erli Sarilita, M.Sc. Ph.D. for moderating the session. In this hard times of pandemic, we can still find the bright sides. I believe that this will be an inspiration for all of us to learn cleft lip and palate more and more, even further to implement best treatments for our cleft patients in the future. Also, for all the participants, please don't forget to join the next live discussion. And before we end today's session, maybe we can take a picture. So for all of the participants, please turn on the camera, and I will have to count 1, 2, 3. Yeah, so for the participants, please open the camera and prepare maybe your best smile to the camera. Okay, I will start counting. 1, 2, 3, cheese. 1, 2, 3, cheese. 1, 2, 3, cheese. Maybe that's it for today. Thank you so much for Dr. Akintububo and also Dr. Erli Sarilita. Thank you so much for everyone. Goodbye. Stay healthy.
Thank you all. Bye-bye.
Thank you, doctor.